Hi everyone, this is Brian Shapiro at CTA Pathology, and today's lecture is on the cutaneous manifestations of nutritional deficiency states. So I thought I would do a short little PowerPoint on the background of all of these, and then we'll show some slides, and then if we've got some time we will do some unknowns. So let's start with this chapter and look at the etiology of this. And the etiology is usually a deficiency of an essential nutrient or vitamin, but other causes of similar clinical and pathologic findings can be a metabolic disturbance where there's problems with absorption, or immune system derangements, which also can lead to deficiency states. So we start with a group with the vitamin, amino acid, and mineral deficiencies. The first one is scurvy, and clinically we see follicular purpuric macules with follicular hyperkeratosis, these characteristic corkscrew hairs with gingival hemorrhage and hyperkeratosis. And in the US, usually we see scurvy in elderly chronic alcoholics because most diets have enough vitamin C. The pathology of scurvy is usually just what matches the clinical: follicular hyperkeratosis with coiled hairs, erythrocyte extravasation, and the reason for these findings is defective collagen synthesis with a deficiency of hydroxyproline. A second vitamin deficiency I wanted to go through was phynoderma. This is very rare. It's vitamin A deficiency. In the US, this is usually found post-intestinal bypass surgery, and clinically you find again follicular plugging with rough skin and night blindness, and pathologically you see again hyperorthokeratosis with a plugged and dilated hair follicle and often sebaceous atrophy. And the differential diagnosis histologically is other diseases with plugged follicles such as keratosis pilaris, lichen planopilaris, and pityriasis rubripilaris. So all the pilaris entities. The third big one is necrolytic migratory erythema, and clinically this is usually due to a glucagonoma secreting alpha cell tumor of the pancreas, often associated with hepatic failure and diabetes mellitus. And clinically these patients present with anemia, weight loss, and mucosal and periorificial lesions. Also, you find lesions on the feet with erosions and pustules and a circinate appearance, and this is then called necrolytic acral erythema. Histologically, these look exactly the same. And then related to the necrolytic migratory erythema is this acrodermatitis enteropathica, which is a zinc deficiency. So these three all have the same pathology, which is an abrupt area of necrosis of the stratum spinosum with hydropic swelling and pygnosis of the nuclei in this area, pallor of the upper epidermal layers associated with neutrophils, and then later on a broad parakeratotic scale with psoriastiform hyperplasia in the later stages, and you find some interface change, and we'll see some slides of this. So the inherited form of this acrodermatitis enteropathica is an autosomal recessive inheritance of zinc absorption. It usually presents in infants at the age of 4 to 10 weeks with an acral and periorificial eruption, diarrhea, and it can be vesicular bullous. And the pathology, as I said, is similar to the other types of necrolytic erythema. So here we have some clinical pictures of scurvy, and these are all from newzealand.net, which is a great site for both clinical and sometimes pathologic findings. You can see the corkscrew hairs with a perifollicular hemorrhage. Over here, quite marked perifollicular hemorrhage, often on the lower limbs. This is on the shin. And then you can have extensive areas of hemorrhage. Look at the ecchymosis over here. Histologically, the corkscrew hairs are characteristic, which you can see here, the follicular hyperkeratosis with the hair which is winding around. Here's a higher power. And then if you look carefully, you see erythrocyte extravasation in this area around the hair follicle. No vasculitis. If we look at the clinical of necrolytic migratory erythema, the circinate lesions, perioral, perianal. Here are the changes on the tongue with some glossitis, I think. And you can see also on the forearm here, extensor surfaces. So we'll look at the pathology of necrolytic migratory erythema a little later. I've got some slides. And then the third big group I want to go through was pyoderma gangrenosum. This is known to most of you as associated with Crohn's disease, inflammatory bowel disease, leukemia or myeloma, often IgA myeloma. This presents with follicular-centric pustules which ulcerate and have a violaceous edge. It's usually on the lower extremity, associated with pathogy and trauma. And interestingly, I saw only 3% of lower leg ulcers are due to pyoderma gangrenosum. So much more common are vascular ulcers and tumors and other causes of ulceration. There are two variants which we should know about, the superficial granulomatous variant and the fascicular pustular variant. So the pathology of this is not entirely specific. You find a central undermined ulcer with underlying dermal necrosis and a dense neutrophilic infiltrate, and then a peripheral perivascular lymphocytic infiltrate with a cuff of neutrophils. So this is adjacent to the dense neutrophilic infiltrate. In the areas of maximal neutrophilic infiltrate, you can find a leukocytoclastic vasculitis, but this is a secondary phenomenon and it's not primary a vasculitic process. The superficial granulomatous variant shows an ulcer with underlying suppurative and granulomatous infiltrate, plasma cells and eosinophils. And obviously, you have to exclude infection in all of these cases, differential diagnosis. Other things to consider are early Sweet syndrome or other neutrophilic dermatoses such as bowel bypass syndrome, rheumatoid neutrophilic dermatosis, and Behçet's disease. Here are some clinical pictures, again from DermNet New Zealand, of pyoderma gangrenosum. You can see, I think this is a stoma site, probably for a inflammatory bowel disease or Crohn's disease, which has had surgery. And here you can see an ulcer with an undermined edge and it's piling up at the edge of the ulcer. This is a characteristic site at the lower limbs with pyoderma gangrenosum. Another similar picture here. Pathology will show later of this. So here we have some slides of pyoderma gangrenosum. You can see this is a nice punch biopsy which has been divided, and even at this power, you can see there's a dense dermal infiltrate with undermined an ulcer and undermining the epidermis. When we go on higher power, we see underlying the ulcer, there's a dense neutrophilic infiltrate with some cytoclasis, but really not much. Just a sea of neutrophils with dermal destruction and necrosis, big abscess. And then adjacent to the area of maximal neutrophil infiltrate, there's a perivascular lymphocytic and occasional eosinophilic infiltrate, but no real vasculitis, no fibrinoid necrosis of the vessel walls, and no significant leukocytoclasis when compared to the density of the infiltrate. And here you can see the infiltrate undermining the epidermis, and even some neutrophil exocytosis with spongiosis. So this is obviously a diagnosis of exclusion. We have to do special stains and maybe even cultures to look for an infectious process. And also the differential is other neutrophilic dermatoses, bowel bypass, rheumatoid neutrophilic dermatosis, even Sweet syndrome. And once those are all excluded and we have the right clinical scenario, you can get to the diagnosis of pyoderma gangrenosum. So here we have another case which is a little later and more well developed. This case, again, a punch biopsy where you can see pseudoepitheliomatous hyperplasia with acanthosis. And you can see we are on the lower limb here because you've got glomeruloid neovascularization and the stasis changes. Here you can see nicely the thickened walls of the vessels in the upper reticular dermis. And then at the edge here, you can see again a dense neutrophilic infiltrate with some destruction of the dermis, the neutrophils between the dermal collagen bundles here. And again, with a pseudoepitheliomatous hyperplasia and a neutrophilic infiltrate, a deep fungus, mycobacterium are going to be in the differential diagnosis, and they have to be excluded. Here you see neutrophilic microabscesses in the epidermis, also a sign of infection. And in this case, there was another interesting thing where I found elastic fibers being extruded through the pseudoepitheliomatous areas. Here we go. And this is what Whedon calls the epidermal vacuum cleaner, these elastic fibers extruding through. And it's, again, a non-specific finding. So again, this case, it was the lower limb, it was an ulcer, infection was excluded, and it was compatible with a clinical impression of pyoderma gangrenosum. Okay, just one more case of this, and here we have, again, a punch biopsy that's been divided, and again, a dense neutrophilic infiltrate in the dermis with no real vasculitis in areas away. So this would be the earliest phase of the disease, where you find a perivascular lymphoid infiltrate with maybe a couple of neutrophils and an occasional eosinophil, totally non-specific. And then as the disease develops, you get this dermal destruction by a dense neutrophilic infiltrate. And in these areas, you might find a leukocytoclastic vasculitis or vasculitis, but it's secondary just to the dense neutrophilic infiltrate. And obviously, in these cases, the other thing to think about is factitia, and polarize these cases to see if there's any foreign material, and then look for infection. And here you can see the characteristic undermining of the epidermis with the neutrophilic microabscess or neutrophilic abscess. Okay, so the next entity, I checked through our files, and this was the only example that I could find. And this is a case where you have confluent parakeratosis on top in a punch biopsy. Associated with mild psoriasiform hyperplasia. See some elongation of the rete ridges. And this takes a bit of a stretch of the imagination, but maybe some pallor of the upper layers of the epidermis over here, or even compared to the normal epidermis there. And then necrotic keratinocytes. So you see one there, see one there at the dermoepidermal junction, and a superficial infiltrate, mainly perivascular, little interstitial, of lymphocytes. So we have this confluent parakeratosis and a psoriasiform and lichenoid. So one of the things you think about is syphilis, with some neutrophils up here. But this turned out to be a patient with zinc deficiency, and this was necrolytic migratory erythema. And this you could see in necrolytic acral erythema. And this patient had these well-demarcated plaques on the hands. So this is just something to bear in mind. If you don't think of it, you're going to miss it. When you look carefully in the infiltrate, you see there are some neutrophils as well. Here's the multi-lobe neutrophil. So that's another clue to the diagnosis. So the next entity I want to discuss is something that you see in children. It's something that follows a lot of infections, different types of infection, and usually it's symmetric on the face, on the extensive surfaces, on the dorsum of the feet, and it presents with usually less than 1 centimeter plaques and sometimes vesicles, and this is Giannotti-Crosty disease. So in the JAD quite a while ago, there was a good review of Giannotti-Crosty, and I will attach this for everyone to have, but this follows many different viral infections: Epstein-Barr, hepatitis, cytomegalovirus, Coxsackie is the one, We haven't seen it post-COVID yet, but who knows, that might be something in the future. HIV, and even some bacteria, Bottonella, beta hemolytic strep, and Mycoplasma pneumonia. Usually the patients are below the age of 4 years. There are some cases with adults. And pathogenesis is unknown. And here you can see these papules on the cheeks, chin, and the ear, symmetrically distributed. And histologically, it's a spongiotic process, but is not entirely specific. And you can see spongiotic vesicles, and Langerhans cell type vesicles are supposed to be more characteristic of this. And you also can see exocytosis of lymphocytes. And here we have a picture of the spongiotic vesicle. Now, in the more chronic non-vesicular form, it just looks like an eczematous dermatitis, and you absolutely have to have the clinical history and the age to make the diagnosis. And often there's some generalized symptoms and signs, low-grade fevers, diarrhea, and I think in up to a third of the cases, lymphadenopathy, and there's a positive Kubner phenomenon in some cases. So I'm going to show a few cases that we've had of genotochrosti. Here's a nice punch biopsy. And one of the clues here is this looks like really clean collagen, and look at these eccrine glands very close to each other. So this says you're dealing with the young individual skin, child. So when you see biopsy from a child, you always know, here, look at these ecrines close to each other. You can kind of narrow the differential. In this case, you can see mild spongiosis and almost normal epidermis, except for here we have a Langerhans cell vesicle, beautiful Langerhans cell vesicle, prominent papillodermal edema, and fairly dense perivascular lymphoid infiltrate with an occasional eosinophil. So this could be a bite, it could be a hypersensitivity reaction, but if this is a child and it's symmetric papules on the face and has exposure to Coxsackie or something before, then this would fit with genotochrosti. Okay, so here is our case where the clinical fitted perfectly. This was bilateral papules and vesicles in a 2-year-old following hepatitis infection, I think. And again, these were 2 separate punch biopsies with focal parakeratosis, psoriasiform hyperplasia, mild spongiosis, and a perivascular lymphoid infiltrate. Really not a specific finding. Little scratch there. And the infiltrate can get quite dense around the mid-reticular dermis. So this could be atopic dermatitis, could be early nummular dermatitis, but in the right clinical setting, this is genotochrosti, and yeah, you can see the early spongiosis. Definitely something to think about in kids. And here one more that had, again, the perfect clinical setting. And on low power, you can see central area of scale crust with underlying mild spongiosis and a mixed perivascular, superficial, and mid-dermal lymphoid infiltrate. With some papillodermal edema, not really a big eosinophil component, an occasional one. And no vasculitis, no real interface change, and again, this in the right clinical setting was genotochrosti. So, in the young individuals, collagen, you can see no significant solar elastosis or sun damage. Okay, so other things in the chapter were Behçet's disease, which is a clinical diagnosis The histology is really not specific. You can find neutrophilic infiltrates, you can find acneiform lesions, you can find enodosum, but none of them help you to diagnose Behçet's. You need the ulcers and all the other clinical manifestations. And so I thought I would go and do a few unknowns, because I think we've covered all the pathologic things you need to know for this chapter. And then obviously the neutrophilic dermatoses, which can look just like pyoderma gangrenosum. The last thing I want to mention is a superficial variant of granulomatous variant of pyoderma gangrenosum. I've seen not lots, but a few cases where surgeons keep taking out ulcers, and they keep looking for infections. And the superficial granulomatous variant of pyoderma gangrenosum has an ulcer with a dense granulomatous lymphohistiocytic infiltrate and then a cuff of plasma cells. So it really does look infectious histologically, and it doesn't often have that characteristic neutrophilic infiltrate that you see in conventional pyoderma gangrenosum. So just remember that entity when the repeated biopsies and infectious studies are negative. So this was the first unknown slide I put out, which was a nice punch biopsy, and even at this power you can see follicular hyperkeratosis with a follicular plug, an area where there are sebaceous glands, and maybe the face or the neck, and a dense infiltrate, superficial and deep, perifollicular and perivascular. You look on higher power, there's really no significant epidermal change. The infiltrate comprised of lymphocytes with a few plasma cells. And then we start looking around and you see there's a histiocytic component, these oval nuclei with distinct nucleoli and pink cytoplasm. And the infiltrate goes quite deep, goes around the annexi. And here we have a nerve, and you can see the infiltrate is sniffing the nerves, and there's a plasma cell as well. If you look carefully over here, this pattern is an interstitial granulomatous pattern, where you have an interstitial granulomatous dermatitis or interstitial granuloma annulare-like pattern, histiocytes percolating between the reticulodermal collagen bundles. And the lymphocyte population is small round lymphocytes with a few larger transformed lymphocytes. So this is a fairly characteristic pattern when you see this granulomatous infiltrate, some perineural invasion, and a few activated lymphocytes. Not perineural invasion, but perineural infiltrate and activated lymphocytes. And this turned out to be a Wolff's isotopic response post-herpetic infection. And these were grouped papules on the cheek of a 55-year-old gentleman. And we couldn't find herpes, but there was enough here to say that this is a post-herpetic phenomenon. So this is a really nice case of post-herpes. Sometimes these cases have a little buzz at the interface as well. This one did not. Maybe here. So looking at dermal infiltrates, the next unknown was again a nice punch biopsy, and let's look through the center. And here you can see these dense nodular infiltrates in the dermis extending into the panniculus with what looks like not a lot of epidermal change. Go on higher power, epidermis looks normal, and these nodules are comprised of multiple types of cells with a central area and then a cuff of blue cells, which are the lymphocytes. And these, for people who know any hemopath, are germinal centers. Centroblasts and centrocytes in the center. These centroblasts are the round ones with the nucleoli. Centrocytes are the cleaved cells. And tingible body macrophages, macrophages with debris in the cytoplasm, some plasma cells, and then a cuff of lymphocytes. So these were well-developed germinal centers. And the differential of this is always a primary cutaneous follicular center cell lymphoma. And I thought I'd go through how do you distinguish a normal germinal center from a neoplastic germinal center. And normal germinal centers have zonation. So you see the tingible body macrophages, which will stay with CD21 in a zone, not all throughout the germinal center. And they have a normal cuff of lymphocytes. The cuff surrounds the whole germinal center. So here you can see these cuff of lymphocytes, which is the mantle zone, and the germinal center is made up of, as I said, the centroblasts, centrocytes, and follicular dendritic cells. Occasional eosinophils were in this infiltrate. This one here. And no epidermal change, as I said, and this turned out to be a case of cutaneous lymphoid hyperplasia or cutaneous pseudolymphoma, B-cell pseudolymphoma. And the question is always how much to work these up. Because as you know, you can find normal-looking germinal centers in a maltoma or marginal zone lymphoma. When there are a lot of or a significant number of plasma cells, I do kappa lambda, and that can show either clonality or lack of clonality. In this case, we did a kappa lambda stain and found that it was not monoclonal, a mixture of kappa and lambda secreting cells. So this was a beautiful case of cutaneous lymphoid hyperplasia. Often these can be persistent bite reactions, can be seen with scabies and drugs, other entities, but we found no evidence of any bite in the epidermis here. This is a B-cell pseudolymphoma, the kind that you could get on board because it has got all the characteristics you need to make the diagnosis. The next case is not a difficult diagnosis, but this illustrates something we see not uncommonly in dermatopathology. This was a punch biopsy from the abdomen, and even at this low power, you can see it's got a square shape and thickened collagen bundles. When you look at this, you can see these thickened collagen bundles are relatively horizontally placed, and this would fit nicely with morphia, scleroderma or morphia. Other features are you see these eccrine glands high up with no periappendigeal fat. So those are the signs of morphia. And sometimes you can see vascular changes, which I'm not seeing here. This would be a beautiful case of morphia next case. And then we looked on top, and we saw a lot of solar elastosis and hemorrhage over here. So this was secondary Bateman's purpura or solar non-inflammatory purpura in morphia. And this just illustrates that before you report a biopsy, you must make sure you don't miss the second diagnosis. And this actually came in as a pigmented lesion. So the clinician had seen the hemorrhage on top, and the lesion was actually morphia underneath with a concomitant Bateman's purpura. Nice biopsy. Next case, the next case was a lesion on the cheek of a 60-year-old female. Rule out tumor, rule out basal cell, I think. And at medium power, you can see there's some scale with hemorrhage and then an endophytic tumor. And when you go a little higher, you can see it's a sebaceous tumor with increased proliferative germinative layer, sebaceous adenoma, sebaceous epithelioma, depending on where your cutoff is. And patient would be worked up for Mia-Torre. Doesn't look like there's a nevus sebaceous in the background. And then when we looked closer at this case, we found there were numerous mitotic figures. There's one, there's another one, one up here. There's a ring mitosis almost. So the question is, what do you do with these sebaceous neoplasms which don't have an infiltrative growth pattern like a sebaceous carcinoma, but they have increased mitotic activity? And there is some pleomorphism. So I thought this was not enough to call a sebaceous carcinoma, but I did want this removed completely, and reported this as an atypical sebaceous neoplasm, and in the note said it has got some features of sebaceous epithelioma, but there's increased mitotic activity, and we should have complete excision and a workup for Myotorray if clinically appropriate. So this is just a little back to day-to-day dermatopathology when lesions don't always obey what you see in the books. Because sebaceous carcinoma is supposed to have areas of extensive necrosis with an infiltrative growth pattern and lots of mitotic figures and big atypical cells. And here we didn't see a lot of that, but we did see lots of mitotic figures. So it's a kind of judgment call. Okay, the next case I put out was an uncommon variant of a common entity. And this again was a punch biopsy. You can see some LSC on top with acanthosis, hypergranulosis, irregular psoriasiform hyperplasia, and then actually some atrophy with loss of the Reti ridge pattern and thinning of the epidermis, and a dermal spindle cell neoplasm with nice entrapment of the collagen bundles, just like you see in a DF. So this could be DF next case, but we don't have the epidermal hyperplasia, we don't have the dirty fingers, we don't have the Gren zone. So what's going on here? And when you look on top here, there's keloidal-like collagen with these thick homogeneous collagen bundles associated with the mononuclear cell infiltrate, some giant cells. And this is just a curiosity. It's a keloidal dermatofibroma. And there have been series of these. They don't have any clinical significance really, and they look just like a conventional DF, but it's a kind of nice histologic pattern. So not everything with keloidal type collagen is a keloid scar, and just an entity to know about keloidal dermatofibroma. The next case was a punch biopsy, and this just is to show how you need to keep an open mind. This was a punch biopsy on the back, came out as rule out BCC. You can see some scale, and even at this power, some acantholysis. Let's go a little bit higher. And here you see acantholytic disc keratosis with core rons and core grains, and this parakeratotic scale on top. And adjacent to this, you see just acantholysis with no disc keratosis, but it's not going down the follicle. And the infiltrate underneath is mainly lymphoid, not eosinophils, and we don't really have an interface process going on here. So could this just be a lichenoid keratosis? Could this be focal acantholytic disc keratosis? And as a single lesion, that's kind of what you would think of. But the clue to this diagnosis is that there are two patterns here. There's pure acantholysis or pemphigus-like pattern over here, where you just see the acantholytic cells separating from the basal layer. And then in the other areas over here, you see acantholytic disc keratosis. You can see that these acantholytic cells are becoming keratinizing. And without the extension down the follicular epithelium, this turned out to be Grover's disease, which was just biopsied as a shave. Sometimes you do find eosinophils in Grover's. Here's one. And not all inflammatory dermatoses are done with a punch biopsy when biopsied, so just keep an open mind. And then the last case, how could I leave without doing at least one melanocytic? This was, I think, a 28-year-old male with a lesion on the forehead, rule out nevus. And this looked like a papule, some thinning of the epidermis, dense dermal neoplasm. You go on higher power, it looks like a conventional nevus here with nests of melanocytes. not pigmented, and some maturation towards the base of the lesion. The melanocytes get smaller. They dissect between the reticulodermal collagen bundles, and while you're cruising around, you see these big ones, these epithelioid melanocytes that look like Spitz-type melanocytes, and inflammatory cells. So here we've got in this field the whole set. Small banal melanocytes, Spitzoid melanocytes with pink cytoplasm, copious and oval nuclei, distinct nucleoli, and a lymphocytic infiltrate. And this, I think, will not be a surprise to many of you. The test to do next would be BAP, because this is a fairly classic BAPoma, or BAP inactivated melanocytic tumor, that's now called. And these, as you know, can be sporadic or inherited. Most of them are sporadic, and they are markers of increased risk for uveal melanoma and other site melanoma. And the immunohistochemistry for this is the BAP protein, which would, in this case, would be lost in the epithelioid cells over here, but retained in the small melanocytes. And this is a nuclear stain, and is becoming more freely available. Most labs have it now. Before we look at the BAP stain, you just have to make sure there isn't significant mitotic activity with these cells, these epithelioid cells, and areas of necrosis, because that could be a melanoma developing in a dermal nevus, which is well described. These nice BAP cells associated with a lymphocytic infiltrate. That's also a clue that Lebois speaks about. This picture here. So here is our BAP antibody, and let's go on higher power and look. This is the banal nevus, and you can see the nice nuclear stain. And then when you get to these more epithelioid cells, there's some cytoplasmic staining, but the nucleus is clearly negative. And if we go to the areas down here that I've shown you before, perfect nuclear stain with a small banal melanocytes, loss of nuclear staining with the epithelioid melanocytes. So this was a classic example of a BAP inactivated melanocytic tumor, BAPoma. Most people are recommending conservative excision with these, but no further workup. And it's something you need to be aware of so that it's not overcalled and we don't get too aggressive therapy for these. So that's all the cases I have, a little shorter today. I'll send out the Giannotti Crosti article so people can have that for reference. And if there are any questions about any of the cases or about deficiency diseases, please just email me. And please, everybody, stay safe and have a good weekend. Thank you.